Hello and welcome to Lecture 6 of the Understanding the ECG lecture series. My name is Phil DeCam and I'm a cardiology registrar. And in this lecture, we're going to be going over broad complex tachycardias. So here are our learning objectives for this lecture. One is to be able to describe the criteria for what defines a broad complex tachycardia. Two is to be able to recognize ventricular tachycardia, and we'll talk about that in a bit more detail. Three is to describe the initial management for a patient with ventricular tachycardia. Four would be to appreciate the difference between ventricular tachycardia and a supraventricular tachycardia with some form of aberrant or abnormal conduction. And five would be able to recognize torsade de pointes and pre-excited atrial fibrillation as forms of broad complex tachycardia. So as usual, we'll start by just recapping the systematic approach to going through the ECG. First, we start with any details we might have available, name or age of the patient, any indications for the ECG, look at the calibration of the ECG, then going on to the rate, how fast is the heart going, particularly the ventricular rate, whether the complexes are regular, and whether P waves precede each QRS complex. What's the cardiac axis? And then moving on to the waves themselves. So the P wave representing atrial depolarization, making sure it's positive in lead 2 to suggest sinus rhythm. The PR interval, the QRS complex looking at ventricular depolarization, and this is going to be very important in our broad complex tachyarrhythmias. The ST segment representing the ventricular plateau phase of depolarization, and then the T wave, which is our ventricular repolarization. So what is broad complex in this setting? Well, as usual, it's defined by the QRS duration. And so if the QRS duration is greater than 120 milliseconds, then that's considered a broad complex rhythm. And in the setting of a broad complex tachycardia, of course, it's got to be a tachycardia. And so the ventricular rate of depolarization has to be greater than 100 beats a minute. So ventricular tachycardia. Well, obviously, this has a QRS duration of greater than 120 milliseconds, and it's a rhythm of a ventricular origin. And the heart rate's got to be going faster than 100 beats per minute. And importantly, it's regular. So the QRS complexes are regular and appear the same. So each QRS complex appears the same as the one before and normally the one after. And that's important for this form of ventricular tachycardia, and it'll help separate it from some of the other broad complex tachycardias that we discuss later. So there are three common mechanisms by which ventricular tachycardia can occur. The first is that you get a small re-entry circuit developing, and I'll show you that in a second. The second is that you have abnormal automaticity, in which you have an area of ventricular cells generating additional impulses. And the third is triggered activity, in which there are extra depolarizations occurring in ventricular cells. And I'll try and tease these apart slightly, if only because the triggered activity becomes important for things like torsade de pointes. And so I'll try and show how these things are slightly different from one another. So I will say that the next few slides here, where I talk primarily about mechanisms, are not absolutely vital, and if you only want the absolute bare minimum to get through exams, I'm very happy for you to skip ahead. But for those of you who are interested in this, we'll go through it in not too much detail. So ventricular tachycardia is a re-entrant arrhythmia. This is probably the most common form of ventricular tachycardia, and essentially what we have here is the end of a Purkinje fiber. And this is our ventricular wall here. I do appreciate that my artistic ability is relatively limited. And you end up with this electrically inert area separating conduction pathways. And that tends to happen at the end of these conduction pathways. They split and split and split, and eventually they split just before the ventricular wall. And in between them, there'll be areas that are essentially electrically inert. And so you get a depolarization going down, and this is in normal tissue. It goes down each pathway, and then it depolarizes the ventricular wall. And the signals come together to cancel one another out. Now, when a reentrant arrhythmia is occurring, you have again the end of the Purkinje fiber in our ventricular wall. And in addition, with this electrically inert area, you also have a depressed area of reduced conduction, often due to ischemia, or there's been bits of that pathway that have been infarcted, so there's only a few cells that are available. And so that has reduced conduction ability. And so what happens is the depolarization comes down, and it goes down the normal part of the pathway absolutely fine. But the small signal from this small Purkinje fiber is blocked by this depressed area, so that signal doesn't get through. And that's fine in the sense that the ventricular wall is depolarized by the fibers that do remain, and so that's absolutely fine, except that signal isn't cancelled out on the ventricular wall, and instead it starts to come back up, that area of depressed depolarization, the bit where that small signal didn't get through. But you've now got a very strong signal coming from the ventricular wall, and that can break through this depressed region. So the signal from the ventricular wall travels up through the depressed region, but it does so quite slowly. There's quite slow depolarization because it's just not very good at transmitting signals, that region. But when it does eventually arrive, it arrives after the Purkinje fiber is fully repolarized and no longer refractory and ready to receive another signal. So the signal arrives there and is able to head straight back down that Purkinje fiber and to depolarize the ventricular wall again, which then comes back up the depressed region again. And you can see how you've developed a circuit here that will just go round and round and round. And that's how you get a reentrant ventricular tachycardia developing. So in comparison, ventricular tachycardia induced by abnormal automaticity, it comes about from a group of cells within the ventricle which act like pacemaker cells. And these separately happen to depolarize faster than the sinus node and cause the ventricle to depolarize very rapidly. And that's quite different from that reentrant circuit where all the cells are kind of doing what they're supposed to do, just some less effectively, whereas this is an added function of a small group of cells. So what are the features that would make you think a broad complex tachycardia was ventricular tachycardia? Well, there are a number of them, but the sort of three cardinal features that we're told to look out for are as follows. So one is the presence of capture beats. And this is the idea that you see a normal QRS complex within the run of ventricular tachycardia. And I'll explain how they come about in a second. The second is AB dissociation. So essentially, the ventricles should just be acting on their own, right? Either through an abnormal set of pacemaker cells or a reentrant circuit. Essentially, the ventricles are doing stuff completely out of sync with the atria. So you should see P waves that are just completely unrelated to the ventricular rhythm, almost as if you've got a complete heart block, but at this time you've got a ventricular tachycardia. And sometimes you'll see something called a fusion beat, which is a QRS complex halfway between the ventricular tachycardia broad QRS beat and a normal QRS complex. And again, I'll explain how those come about in a second. So let's talk about capture beats. So let's imagine we've got our lead looking somewhere around here, and it's seeing nothing at the moment, but then you've got a pacemaker cell and it fires off. And you can see that our lead is looking exactly where the pacemaker cells are, or that site of the ventricular tachycardia is. And so all of the depolarization is occurring away from it. So you get this deep S wave occurring. And then you have your T wave. Now, so while you've got the ventricles in their ventricular tachycardia, the atria are just carrying on unaffected. And so they depolarize as normal. And you get these P waves. And as we've said, these can be unrelated to the QRS complex. And so the atria may depolarize, and the ventricles are also depolarizing frequently. And so you'll get these broad QRS complexes, as we've mentioned. But importantly, this depolarization from the ventricles normally prevents signals coming down from the atria into the ventricles. So you get these P waves, but you don't get any narrow QRS complexes from them. But that's not always the case. So if it's timed just right, the atria depolarize, and the signal reaches the AV node when the ventricles are repolarized and ready to receive a signal. but the pacemaker cell hasn't fired just yet, and so the ventricles depolarize normally down their normal conducting system, and they get a normal looking QRS complex. And so it has to be timed absolutely perfectly, but you can get this capture beat just within the run of VT, and then it may just go back into VT straight afterwards. And so you just get this random normal looking beat as a capture beat, and that's very, very suggestive. Well, basically it's diagnostic of ventricular tachycardia. So what about fusion beats then? Well, if it's timed almost right, but not quite, what might happen is the atria depolarize and the signal reaches the AV node when the ventricles are ready to receive a signal, and they're no longer refractory, and the ventricular focus fires at the same time. Well, then you kind of get this combination where the depolarization of the ventricles is a mix of the two. So some of it is using the normal conducting system, some of it is coming from that ventricular origin, and so you get this sort of halfway house, this hybrid fused QRS complex, and that's a fusion beat. So it won't quite be as wide as the ventricular tachycardia beat, but it won't be completely normal either, and so you get this sort of halfway house. Okay, so time for an example ECG. So I'll give you a couple of seconds to pause the presentation, and then you can go through it in your own time, and then I'll go through it to catch up with you. Okay, so hopefully you've had a chance there to go through it. So starting with details, I think we can probably assume, looking at the ECG, that this patient is relatively unwell. So from a technical point of view, it looks like it's calibrated normally based on those rectangles on the left side. In terms of rate, it looks like we're going pretty fast, doesn't it? So if I pull out lead 2 here, you can see there's about 2 large squares between each R wave, and so we're going at around 150 beats a minute there. In terms of rhythm, well, that R wave, that RR interval there, we can see is pretty much the same as it is between that one, or if we move it to there, it's the same as well. So it looks regular. Okay. Now, in terms of whether it's sinus rhythm or not, it's a little bit difficult to tell, isn't it? Because I can't see any clear P waves, which I guess points us against that. What about the cardiac axis? Well, let's have a look at that in detail. So here's leads 1 and 2. Here's our graph that we normally use. So what about lead 1? Well, lead 1 is downward going, isn't it? So, all right, that must mean that it's going away from lead 1. So we can get rid of everything on that right-hand side of our graph. Okay, what about lead 2? Well, that is also down going, isn't it? And so that leaves us in a very weird area where we're either very extreme right axis deviation, or we're in what we've called the northwest axis. And if you remember back to lecture 1, there's only a couple of causes for northwest axis. So the key one that we should be thinking about is ventricular tachycardia with our broad complex here. But the others are whether you've got limb lead reversal. So if somebody's put the left arm electrode on the right arm and vice versa, that can cause this as well. So those would be the ones to really think about. Sometimes dextrocardia and extreme right axis from right ventricular pathology can cause this. But I think VT's got to be top of our thoughts here. And indeed, we can show that this isn't just extreme right axis by looking at lead 3, which is also negative, which really does mean that this is properly right up in that northwest territory. So what about P waves? Well, I can't really see any P waves, to be honest. And I don't, therefore, can't calculate a PR interval. What about the QRS complex? Well, I think that's got to be where our money is, right? So let's pull out a couple of leads here. Well, certainly it's broad, isn't it? So 160 milliseconds is really getting on and very broad, actually. And if we look at it here in lead 2, we can see that it's the first part of the QRS complex that's really broad. Okay, so that bit from baseline down, in this case, to the bottom of this Q wave is taking 100 milliseconds. Okay, now if you remember back to our discussion of bundle branch block, you remember that actually the first bit of the QRS complex in bundle branch block is normally quite quick. that's the bit going down the bundle that's not blocked. So in right bundle branch block, it's the bit that's going down that left bundle. And the bit that's broad is the bit where it's trying to get through the ventricular muscle at the end. So you have a sort of pretty narrow bit and then it gets broader. And that's particularly the case when you're looking at that slurred S wave in V6 of right bundle branch block. And here we have something that's kind of the opposite. So if you look, it's that first bit that's really broad, and then the latter bit is actually not as broad. And so that's very different from bundle branch block, and that should really make you go, even if this looked like bundle branch block, which I don't think it does in this case, this would really go against that. And you can see here, this is an example of left bundle branch block, and you can see that that first bit, that whole first bit to that deep, deep S wave there in lead V3 is taking 40 milliseconds. And so that's very different. And you see that after that first bit is where all the rest of the time takes. And that's taking at least 80, 90, 100 milliseconds to complete that upstroke at the end. Okay, what about the ST segments? Well, they're difficult to tell, aren't they? And the same goes for T waves. They're difficult to see, but there is some T wave inversion certainly in V1 there, I can see. But I'm not sure that that's the key bit. So summary, we've got a broad complex tachycardia with an extreme axis, and we've got a slow initial part of ventricular depolarization. And I think these features are all very much in keeping with ventricular tachycardia. Now, obviously, there aren't any fusion or capture beats on this trace, and that would really help us clinch this diagnosis, but I wanted to show you some other bits that really make you think, could this be ventricular tachycardia? Because otherwise you might go, V1 there kind of looks like an M, and V6, I could buy that as a W, so is this just right bundle branch block? And I think the things that really go against that here are, you've got a really broad QRS complex, and going really quite quickly as well. Okay, so that goes against it being a bundle branch block morphology. You've got this northwest axis, which is just not part of either the left or right bundle branch block. And you've got that slow first part of the QRS. So this, what is called an RS interval, is greater than 100 milliseconds. So what about SVT with aberrancy? Well, this can mean a few things, but mainly it means that you've got this supraventricular tachycardia, so really AVRT, AVNRT that we discussed in the last lecture, in somebody who already has left or right bundle branch block. And in that situation, the rhythm will be a broad complex tachycardia, even though it's from a supraventricular origin. The other way that this can come about is that you get what's called antidromic AVRT. And so you get the circuit of AVRT, which is our arrhythmia that requires that accessory pathway, going, in inverted commas, the wrong way around. And by wrong way, I just mean the other way around from the way that it goes when you get your narrow complex tachycardia. And I'll show you an example of that in a second. So here is our AVRT with an antidromic circuit. So the correct way around, the way around that I showed you in the last lecture, or the normal way around, it's called the orthodromic circuit. And the antidromic circuit just works something like this. So your ectopic beat occurs in the atrium, just like it does when you have your orthodromic. But it happens to hit the AV node while it's refractory. And instead, the signal passes down the accessory pathway. And so the ventricle depolarizes relatively slowly via that accessory pathway going into the ventricular muscle. So it doesn't use the standard conducting pathway. And then the AV node is activated via the ventricle. And then the signal comes up via the AV node into the atria and then depolarizes the accessory pathway. And this circuit goes round and round. But you can see, because it's not using the standard conducting pathway of the ventricle, you end up with this broad complex rhythm. So I've talked about some of the minutiae of ventricular tachycardia, which I think are interesting. But I think if it's the middle of the night and you're an F1 on a night shift and you get called to see somebody, your real question is this VT, or at least should I treat it as VT? And so this is the flowchart that I would recommend. So firstly, we're talking about a broad regular rhythm here, right? So if it's not broad and regular, then it's probably not sort of this monomorphic VT that we've been talking about. So it's broad and regular. Question is, are they unstable? And by unstable, I mean those same four things that we've talked about with the narrow complex tachycardias. So do they have chest pain? Do they have features of heart failure? Are they in shock, or have they been syncopal? I think if the answer is yes, then you should treat this as VT. Okay, simple as that. No faffing around. Okay, if they're not unstable, so you've got a stable patient, the next question is, do they have coronary artery disease, or do they have significant risk factors for coronary artery disease? And I think if the answer is yes, then you should treat them as ventricular tachycardia. So in people with coronary artery disease, the chances that a broad complex tachyarrhythmia is ventricular tachycardia is about 90%. Okay, and so just play the numbers here and treat them as VT. And the reason why I'm being cautious, and you'll see the rest of this flow chart, I'm very cautious saying that you should treat most things as VT, is simply that if you treat a supraventricular tachycardia, like ventricular tachycardia, it will still work to get them out of that abnormal rhythm. However, if you treat ventricular tachycardia like a supraventricular tachycardia, you go down that pathway of trying vagal maneuvers and adenosine, that won't do anything for the VT. And so there's plenty of time during that for the patient to become unstable, and you've just given them a treatment that has absolutely no chance of benefiting them. Okay, so I'd be very cautious about ascribing a broad regular tachycardia as not being VT. So let's say you've got a stable patient and they don't have coronary artery disease or any real significant risk factors. Okay, are they young? And by young, I mean, are they in their 20s, 30s, maybe 40s? I think if the answer is no to that, again, I would treat it as ventricular tachycardia. Now, let's say they are young. Is there a clear bundle branch block morphology? Okay, so you've now got a stable patient who's young and has no coronary artery disease or risk factors. If you've got a really clear bundle branch block morphology, then maybe. But if it's not, if you can't convince yourself that it definitely looks like either left or right bundle branch block, then again, you should treat it as VT. So if you do have that bundle branch block morphology in a young patient without coronary artery disease or risk factors, and they're completely stable, then give it a shot. You can consider treating it as SVT. Now, all of this goes with the caveat that if you've got a broad, regular tachycardia, you should have called for help already. Okay. Now, if you've tried treating it as SVT and it doesn't work, I would have a very low threshold for switching to your VT treatment. Okay. And they say that only doctors who think too much kill people in ventricular tachycardia because they think that it's SVT with aberrancy. Okay, and that's what I'm trying to drill home here, is that you really, really need to have a very good reason for thinking that it's not VT in this situation. Okay, so how do you get on and treat VT? And this comes from the Resus Council guidelines, again, that I've adapted. I have somewhat simplified them, simply because I think that at the stage of finals, and even as an F1, I think I would be really trying to keep this as simple as possible and keeping the patients as safe as possible. Okay, so you take your ABCD approach. This is the same as we talked about for the narrow complex tachyarrhythmias. And so you get your observations as quickly as possible. You want to get IV access, bloods, and an ABG. And you want to get some ECG monitoring and a 12-lead ECG if possible. And again, that 12-lead ECG is primarily to allow you to work out if it really was VT later on. Okay. As part of that ABCD approach, hopefully you've been able to establish if the patient has a pulse or not. If the patient doesn't have a pulse, then it's a cardiac arrest call, okay? And it's as simple as that. You need to start your cardiac arrest protocol with your chest compressions and put out a cardiac arrest call. Okay, so if they do have a pulse, do they have unstable features? And again, these unstable features are exactly as we've been talking about on the last slide. So any chest pain suggesting myocardial ischemia, shock, syncope, or features of heart failure. I think if the answer is yes, again, I would be putting out a cardiac arrest call. And I say that as somebody who sees a fair bit of ventricular tachycardia. I think I'd put out the cardiac arrest call because this person is going to need some degree of electricity to get them back into a normal rhythm relatively quickly. And that needs to be done with the appropriate support. Okay, I think if they've got no unstable features, then still you're going to want to get help. But your help might, in this case, be from the medical registrar in the first instance. Okay, and then if they're stable, in some cases we can try IV amiodarone before trying to shock them, and that can be very effective at cardioverting them into from ventricular tachycardia into sinus rhythm. You'd be surprised by the people who can remain pretty stable for some period of time in ventricular tachycardia. Okay, so I think it's time for another ECG example. As usual, feel free to pause the lecture, go through it and try and interpret this ECG, and then we'll go through it together afterwards. And I think while you're interpreting it, I'd really have a think about, is this the same or how is this different from the ventricular tachycardia that we looked at just previously? Okay, so details, well, we don't have a huge amount of details here. From a technical point of view, it appears to be calibrated properly. Now, I do appreciate this is a black and white ECG. The quality of the pink paper behind is not as good, so some of the timing stuff can be a bit more difficult. In terms of heart rate, well, here's a rhythm strip, which I couldn't include on the full thing, but you can see that we've got 32 beats here across the 10 seconds, and so we're going 192 beats a minute, so that's quite quick, isn't it? What about the rhythm? Well, those are two complexes, and they are completely different gaps apart from one another, aren't they? So actually looking at this appears to be irregularly irregular. Okay, and I think that's very important. That's very different from ventricular tachycardia, which is regular. Okay, so this is irregularly irregular. Now, I know that when we say the words irregularly irregular, what springs to mind immediately is atrial fibrillation, and that's good because that's probably what we have. Okay, what about the axis? Well, we'll pull this apart. So lead 1, well, it's primarily downgoing, isn't it? Okay, so we know the axis isn't normal. Okay, what about lead 2? That also seems to be downgoing. Okay, so again, we've got this northwest axis appearing. Okay, and that's unusual, isn't it? So again, that goes against this being a bundle branch block issue. Because we move on to the P waves, I can't really see any P waves here, which again is in keeping with this being atrial fibrillation. And again, that makes the PR interval impossible to calculate. So what about the QRS complexes? Well, they're certainly not narrow, are they? If we pull a couple out here. So, could this be an M and a W? Well, I don't really think so. If you look here, these are the same ECG leads that I showed you when we were talking about bundle branch block, and you can see that actually you've got this monophasic R wave in V1 in this current tracing. And if you remember, we said you had to have this RSR prime pattern in right bundle branch block, so we don't have that. And you've got this large, deep S wave that you don't see in right bundle branch block. If you remember, in right bundle branch block, you see that relatively small but slurred, wide S wave. And so this actually, although it might look like an M and a W, it's very different from right bundle branch block. And I think the other thing to say about the QRS complex here is that they're not consistent. So you see that the heights vary quite a bit, the amplitude of the QRS complexes, they vary quite substantially, and you can see that quite clearly in V4 in the top right. And also how broad they are varies. And so it's all very weird that the complexes are changing very frequently. So what about the ST segments? Well, they're pretty difficult to make out, aren't they? I think you could probably say there might be some ST depression in V5, maybe, but I think that it's very difficult to tell with that very broad complex. And the same goes for T waves. it's difficult to really make out exactly what's going on with them. So in summary, what we've got here is a broad complex, irregularly irregular tachycardia that doesn't fit with a bundle branch block morphology. And the QRS complexes are very irregular, both in terms of the RR interval, which is irregularly irregular, but also in terms of their amplitude and their breadth. And these features together are really in keeping with pre-excited atrial fibrillation. Okay, and so the key features here are you've got a broad QRS complex, you've got this northwest axis, and you've got an irregular. And with that, you don't have the normal bundle branch block morphology, and those QRS complexes are just very weird. Okay, so what is pre-excited atrial fibrillation? Well, I mean, very simply, it's atrial fibrillation in somebody who has an accessory pathway that's able to conduct signals very quickly from the atria to the ventricles. So to show how that works, I'm just going to quickly recap accessory pathways and normal heartbeats and accessory pathways. So you've got the atria and ventricles normally being electrically isolated, and the AV node being the only way signals can get from the atria to the ventricle. But in some people, you have an accessory pathway, an extra bit of tissue that electrically connects the atria to the ventricles. And so you have a normal heartbeat starting at the sinoatrial node. That causes atrial depolarization with your P wave. And the signal reaches the AV node, and that is normally your PR segment. But in people with an accessory pathway, the signal also passes down that accessory pathway into the ventricles while the signal is still in the AV node. And that causes the ventricles to start to depolarize slowly. And because this is bypassing the AV node, the PR interval is shortened, and you get this slurred upstroke in the QRS complex. And then the signal is kind of released from the AV node, and the ventricle depolarizes down the normal conducting system very rapidly and kind of catches up with that initial depolarization of the accessory pathway. So the rest of the QRS complex becomes narrow. And it's possible, though, that the overall QRS complex may be broad because of that delta wave. And then you get ventricular repolarization. And so in atrial fibrillation, what you have is, unlike just having the sinoatrial node firing off once a second or so, you have uncoordinated atrial electrical activity. And these are lots of focuses of depolarization, and they tend to be primarily found in the pulmonary vein inlets. And these fire off lots of signals, and these signals travel to both the AV node and the accessory pathway. And so you get depolarization of the ventricles partially through this accessory pathway and partially through the AV node. And so you can get this broad QRS complex that results. But there's hundreds of signals coming down to the accessory pathway and the AV node. And so the breadth of the QRS complex kind of depends on the proportion of the ventricle being depolarized via the AV nodal His-Purkinje system, the normal conducting system, versus how much is coming from the accessory pathway. And that can change on a beat-by-beat basis, which is why we were seeing different amplitudes and different breadths of the QRS complex on that previous ECG. And you get this irregular rhythm because it's atrial fibrillation, and you get this changing QRS morphology. Okay, so why does it matter? Well, why does pre-excited AF matter? Is it not just atrial fibrillation? Do we not just treat it like atrial fibrillation? Or is it not just an SVT and an AVRT? Do we not just treat it like that? Well, no. Importantly, we shouldn't. Okay. So most antiarrhythmics slow conduction through the AV node. And if you remember in the last lecture when we were talking about AVRT and AVNRT, our mainstay for treating it was to block the AV node to stop that circuit. Okay, and we did that with adenosine. And it's the same with atrial fibrillation. We talked about the fact that actually rate control is the primary treatment option for atrial fibrillation. In most people, apart from symptomatology, there's no benefit of rhythm controlling in most forms of atrial fibrillation. And so you rate control by giving drugs that slow conduction through the AV node, principally beta blockers or non-dihydropyridine calcium channel blockers, or even digoxin. Okay, so these all work through the AV node. And so I've pulled them out here, these four, A, B, C, D. Okay, so adenosine, beta blockers, calcium channel blockers, digoxin. They all work through slowing conduction in the AV node. Now, in pre-excited AF, that is a big problem, because if you block or slow the AV node considerably, that just leaves the accessory pathway as the only or at least dominant pathway. Now, the AV node has a prolonged refractory period. Its job, in part, is to slow the number of, or reduce the number of signals that get from the atria into the ventricles. And we see that in things like atrial flutter, where although the atria is going 300 times a minute, actually the ventricles will normally go at 150, 175, all because of the AV node. Whereas if we block that AV node, then the pathway, when we've got an accessory pathway, the signal will go down that accessory pathway. And that becomes a problem, because if the atria are fibrillating, and then you've got an accessory pathway that can conduct almost as fast as the atria are fibrillating, you then get a direct connection between the atria and the ventricles. So AF becomes VF. Okay, so you take a bad situation, make it much worse by giving any kind of drug that blocks the AV node. And that's why I'm keen to show you this arrhythmia. So what do you do if you think you see this rhythm? So you've got a broad, complex, irregular rhythm with a dodgy axis, or you see that the QRS complexes are changing in breadth and amplitude between beats. Well, you need to get help immediately. Okay, these patients can become very unstable very quickly. You've got to avoid any of those drugs that are going to block the AV node. And I think, giving some electricity, doing a direct current cardioversion is probably going to be the best course of action in conjunction with ischemia. Now, you can consider giving amiodarone, but I don't think these are decisions that you as a junior should be making. You should be getting the medical registrar involved at the very minimum. Okay. All right, so what about torsade de pointe? Well, torsade de pointe just means twisting of points in French, and it's a specific type of ventricular tachycardia, really. And this comes back to that third way that we talked about ventricular tachycardia being formed. So we talked about the abnormal automaticity, the idea of having a pacemaker region that's firing off, and we talked about that reentrant circuit arrhythmia that can develop, but this is that third type. Okay, so this is our ventricular myocyte, and it's its action potential over time as it depolarizes and repolarizes. And this is our QT interval. And essentially, in prolonged QT syndromes or in situations, that QT interval gets longer. But it's not uniform, and you've got to imagine that the ventricular myocytes have a normal distribution of time that they remain depolarized within any individual heart. So some of them will have very long QT times, some of them will have quite short QT times. But as that QT interval globally gets longer, that distribution of QT times will get broader. So the distance between those that have short QT intervals, those cells, versus those that have longer depolarization, repolarization times, that will get further apart. Okay, so we're going to take our heart model here, and we're going to chop a line through it and look down at the left ventricle. Okay, and I've got another donut for you. So this is not the AV node like we saw in the last lecture. This is now our left ventricle. And this is what happens in a normal heart with a normal QT interval. Essentially, we've got our left ventricle, and it depolarizes, and then it repolarizes. Okay, and that's what happens. And you can see that there's some variation in the repolarization, but it all happens relatively together. Okay, well, what about in a prolonged QT interval? Well, we get our depolarization, and then because that distribution of depolarization times is broader, our repolarization takes place over a longer period of time. Okay, and what can happen is that you get areas of the heart that might be still refractory, these blue areas, versus areas that are ready to depolarize again. And this is all while the heart is still repolarizing. And so what can happen is that you can get an ectopic focus, just a random cell just happens to fire off there. So it's not the same as that sort of group of pacemaker cells. It's just a random cell happens to get an extra depolarization, an after depolarization occurring. And if it happens to occur in an area where there are other cells that are ready to depolarize, you can get this new wave of depolarization going off. And you can see that's depolarizing through this white area that was non-refractory, ready to depolarize. And so now you get this depolarizing wave, which is the blue, and behind it is all the cells that are still refractory, but it keeps moving into areas that have become ready to depolarize again. So it keeps moving round and round. And by the time it gets back to where it was before, those cells that started this all off again are ready to depolarize again. And so it never really catches its tail, and it keeps going round and round. Okay, so I've got an ECG example for you here. This is only a single strip, and so I apologize for that, and I won't expect you to go through the whole thing, but just take a couple of seconds and try and pick out the bits that look most bizarre to you or make you think. Okay, so I won't go through it systematically because we've only got this one lead, but I think the key thing to show here, well, there's a couple of things, but one, you've got this broad complex rhythm that develops, but you've got these complexes that they're not uniform and regular, so they don't all look the same as each other. So it's not ventricular tachycardia, that monomorphic ventricular tachycardia that we were talking about before. Okay, but importantly, there is a pattern to it, isn't there? You get this kind of sinusoidal pattern where the complexes get very small and then they get big again and then they start to get small. And this is characteristic of torsade de pointes. And that's because it's this signal just rotating around the ventricle, round and round. And so unlike the ventricular tachycardia either coming from that small reentrant circuit or from that area of automaticity, which are firing off from the same place each time, therefore the QRS complexes look the same each time, with the exception of fusion and capture beats. Here, it's changing the whole time because it's just rotating around the ventricle. So that's one thing to say. The other is, if you look at the very far left-hand side, you see a ventricular beat that looks very different. And this is probably a normal ventricular beat for the patient. And then they have this T wave, and just as the T wave is ending, you've got this other little depolarization that occurs. And this is what's called an R on T phenomenon. So you've got an R wave, this ventricular depolarization, occurring on a T wave. And this is exactly what I was talking about in those previous slides. So you've got this little area that's just suddenly depolarized within the T wave. So during the T wave is the ventricle repolarizing. So you've got some area of cells that is ready to depolarize again. And you then set off this whole arrhythmia from that. And so this is torsade de pointes. Okay, so torsade de pointes again. I think the key things are it's polymorphic, so the shape of the QRS complexes and the cardiac axis is changing as it just rotates around the ventricle. And the treatment here is normally magnesium sulfate. So if you give IV magnesium sulfate, just happens to be a quirk of torsade de pointes that it happens to be very responsive to this. So you can normally give that, and the patient will revert back to sinus rhythm. Now, that is not to say that you couldn't shock these patients and get them back into sinus rhythm. Some people have a misguided belief that you can't do that, but you certainly can give them a cardioversion and get them back into normal rhythm. But normally, magnesium is sufficient. And I think the thing to say just about the polymorphism of the QRS complexes is I hope you could see in that example ECG how different that was from pre-excited AF. So although it's not the same each beat like it is in monomorphic VT, it's still got a pattern to it, it's still got a regularity to it that makes it very different from that pre-excited AF. But I think as with any of these broad complex tachycardias, my take-home message really is, and I think it's the one thing that you take away from this entire lecture is, if you see somebody with a broad complex tachycardia, really you should be getting help, because even if they look stable right now, they can become unstable, and having more pairs of hands is always a plus. And I wouldn't be afraid, if it's a broad complex tachycardia, of putting out a cardiac arrest call if I was worried. Okay, so that's the end of this lecture. And so I just want to go through the learning objectives, make sure we've covered everything. So one, we've described the criteria for a broad complex tachycardia. So essentially the QRS complex is broader than 120 milliseconds, and it's going faster than 100 beats a minute. We've talked about ventricular tachycardia, and we've talked about how to recognize it. And so in particular, it's things like capture and fusion beats you might be looking for. You're looking for a broad complex regular tachycardia, okay? And that's crucial for VT. It should be broad complex and regular. And there are some features that might make you suspicious this was ventricular tachycardia over another cause of broad complex tachycardia, for example, left bundle branch block in somebody who happens to be going quickly, and that's the cardiac axis in particular. But also, I think the key way of thinking is that if it's broad and regular, this is VT until I've kind of proved it otherwise. Okay. We've described the initial management for a patient with VT, and essentially it's get help, and if they don't have a pulse, it's a cardiac arrest. And hopefully you've been able to appreciate the difference between ventricular tachycardia and either SVT with aberrant conduction or that antidromic form of AVRT. And just to hark back again, I think the key thing is that if in doubt, it's ventricular tachycardia. Okay. We've gone through and we've looked at torsade de pointe and pre-excited AF, and I think you can see how they are quite different from your standard VT, but they're still very important and require aggressive management. So torsade de pointe is that sort of sinusoidal pattern where the QRS complexes are getting bigger and then smaller again, and that can be initially treated with IV magnesium sulfate, but I have a very low threshold for getting a lot of help around you. And pre-excited AF, which is irregularly irregular, and you've got those changing breadths and amplitudes of the QRS complex, and it needs to be treated very seriously, and you need to remember not to give any of those drugs that block the AV node. So as usual, if you've got any questions, feel free to drop me an email or touch base with me on social media. I'm very happy to try and answer any questions you might have, or try and put you in the direction of some resources that might be able to help. And one way or another, I hope that you've enjoyed the lecture, and that I'll see you for lecture 7, which is our final lecture.